Well, it's about 2 minutes after the hour, and I think we've had the ability for everyone to join. So welcome. I'd like to thank you for attending this session of Health Talks. I'm Kristen Will, Director of Clinical Programs and Accreditation in the College of Health Solutions and Clinical Associate Professor. And again, thank you for joining our Health Talks provided to you by the College of Health Solutions at Arizona State University. The College of Health Solutions addresses the challenges that face our people and communities within our area and around the globe to stay healthy, improve their health, and manage chronic disease. And the Health Talk sessions is just one way that we serve our community with timely and relevant educational talks that also provide continuing education at no cost. So with that, I'd like to do just a couple housekeeping items. First of all, this session is being recorded and will be uploaded actually to the ASU Health Solutions website. Can be accessed there for reviewing after the session. We'd also like to note that any of the question and answers should be placed in the Q&A and not the chat function. We'll be having time for Q&A approximately 10 minutes after each presenter presents their material today. So we'll look forward to your questions in the Q&A session. Lastly, we will be sending out a brief survey after the webinar today to get input on how you like the session, how we can do better even for next time. And also for those that applied for the continuing education units, this will be your entree into receiving your CEU certificates as well. So each of our panelists, which I'll introduce in just a second, will have around 15 minutes to present their material. And as I mentioned, we'll have around 10 minutes for Q&A at the end of our session. So with that, I'd like to introduce our topic for today, Dueling Epidemics, the opioid crisis in the era of COVID-19. Joining me today is Dr. Raminta Danilatite. She is Associate Professor at the College of Health Solutions, Arizona State University. Dr. Danilatite joined ASU in 2020 with over 15 years of experience conducting substance use research. Thank you, Dr. Danilatite, for being here. Our second speaker today is Dr. Holly Geyer. She is a physician hospitalist in the Division of Hospital Internal Medicine at Mayo Clinic, Arizona, with specialty licensure in addiction medicine. She supervises the Arizona Division of Hospital Internal Medicine Research and Quality Improvement Projects to ensure high quality patient care with enhanced treatment protocols and streamlined institutional processes. And she's actively involved in this area, substance use and abuse, across the enterprise at Mayo and actually across our state. Finally, Dr. Adrienne Lindsay is the Associate Director for the ASU Center for Applied Behavioral Health Policy, with faculty appointments in criminal justice and social work at the Watts College for Public Service and Community Solutions. Dr. Lindsay is also a faculty associate in the behavioral health in the College of Health Solutions. So I'd like to thank all of our panelists ahead of time for sharing their expertise. I'm looking forward to this. And with that, I will turn it over to Dr. Danilatite, who will be presenting first. Thank you so much.
Well, thank you so much. It's really a great opportunity for me to talk to you today and really thankful for this opportunity. So my goal for this session, a very brief session, is to really provide a very brief overview of the key trends in relation to opioid-related overdose mortality. And I just want to first acknowledge a few data sources that I'm going to use for this presentation. I'm going to use CDC data reports generated by NIDA, as well as state unintentional drug overdose reporting system. And I'm also very excited to provide some preliminary data for you based on our interviews with service providers and individuals who use illicit drugs in Arizona. And this research is supported by the CHS grant, COVID-19 seed grant. So historically, we need to acknowledge that the rise of the opioid epidemic really could be outlined in three distinct but also overlapping waves. And this graph really displays these waves very clearly. So the start of the epidemic was really instigated and driven initially by the misuse of pharmaceutical opioids such as Vicodin, Percocet, OxyContin, and others. Around 2010, we started seeing increases in heroin-related overdoses. And these increases were driven by increased transitions of people who use illicit opioids and then transition to heroin because of availability trends, decreased access of pharmaceutical opioids, or increased access and decreasing prices of heroin. And the third wave that you see, that is the third wave that we are living through right now, is the wave that is marked by increased presence of fentanyl and other novel synthetic opioids. And here I just want to make an important note that these fentanyls that is really causing the problems right now for us is not pharmaceutical grade fentanyl. Fentanyl is also available as pharmaceutical drugs as duragesic patches. What we are seeing right now is fentanyl that is produced illicitly and distributed by criminal organizations, and also available on dark web in some situations. So another important aspect that we need to kind of pay attention to is the very important regional variability that we see with overdose mortality trends. So as you see, around 2017 is when if you remember the last slide, is when we were seeing sharp increases in fentanyl-related overdoses. We started seeing this diversification in trends, very sharp differences among different states. And of course, there are important historical differences, socioeconomic differences, policy environments that are different. But one of the important factors that really made big difference in these changing and evolving trends was the fentanyl and the different levels of fentanyl contamination in the drug supplies that were available in different states and different regions of the country. So for example, Arizona and neighboring states initially saw a slower expansion of illicit fentanyl markets, but it is changing. And as you can see from the last map, 2018, these gaps are slowly closing in relation to differences between Arizona and some of the hotspots in Midwest and Northeast. And this slide just provides a different view on these trends, but it really provides a very clear depiction of increasing fentanyl-related overdoses. And this yellow line that you see here, it's labeled as synthetic opioids. And this is the category that includes fentanyl and fentanyl analogs and other novel synthetic drugs. We also always want to have more recent data. You know, it's not always easy to get that. It takes time to process the data and make it available for us. So these data come from the state and intentional drug overdose reporting system. It captures data from the second half of 2019. And as you see, we had 643 opioid-related overdoses in Arizona, and over 66% of all of them tested positive for fentanyl and fentanyl analogs. So this is really an important aspect to consider and understand, that fentanyls are really becoming predominant opioids that are causing problems for us. And so why fentanyl type drugs are so harmful and really causing such huge increases in mortality? First, I wanted to emphasize that fentanyl we are talking about is not the pharmaceutical fentanyl. This is fentanyl that is produced illicitly. It includes fentanyl analogs. So it's not one drug, it's just a changing array of drugs that may have different types of potencies. And they are also very difficult they often go undetected because of a lack of testing capacity. So we have carfentanil that was causing enormous harms. That's one of the most potent opioids known to mankind. And it was really prevalent in Ohio. I am coming here to Arizona from Ohio, so I was seeing firsthand the harms that were being caused by these drugs. Fentanyls are also highly potent opioids. They are more potent than heroin, so that's a very important aspect to understand. And also the potencies vary significantly. So one analog may be 10 times more potent than heroin, another analog might be 100 times more potent. And so we are living in an environment, or people who are using these drugs, they are in a situation where the environment is extremely unpredictable and very, very dangerous for that reason. Illicitly manufactured fentanyl products are available as powder, and that was what we were seeing in Ohio. That was predominant form of fentanyl, or still is. In Arizona, what is happening is that we are seeing increased presence of pressed pills. And these pills mimic oxycodone pills or other types of pharmaceuticals, but they really are fentanyl pills, and they cost less than the real products, and they are highly available and increasing in availability. Another important aspect about these trends is that fentanyl may also be present in non-opioid drugs, such as benzodiazepines, cocaine, methamphetamine. Benzodiazepines that are being sold on the street, so illicit pills. And this, of course, places many people at increased risk because they might not know that the drugs are contaminated, and they consider themselves as low risk for opioid-related overdose because they are not choosing to use opioids. But then they may become exposed to these very dangerous drugs. So what is happening in relation to COVID situation? So these are the most recent data that we have. It was released in December of last year. And what we see is that in the 12 months period ending in May 2020, we had in the country, we had over 81,000 overdose deaths. And this is the highest number ever recorded in a 12 months period. And it shows about 18% increase compared to the previous period, 12 months period. So we're clearly seeing these increases, and this time period, of course, captures about 3 months of our COVID pandemic time period. And the same trends are also seen in Arizona. So in that time period, there were over 2,200 overdose deaths. And it's also the highest number ever recorded, and it shows about 24% increase. So increases in Arizona are greater compared to the national average. So why do we see these increases in relation to COVID pandemic? And still, of course, it's still difficult to say, we don't have enough data. It's still, we're in the midst of this situation. However, I'm very excited to present very preliminary insights from our qualitative data that are being collected for our CHS COVID-19 Seed Grant project. So one of the important themes, so we are conducting qualitative interviews with treatment providers, other service providers, and also people who use illicit drugs. And one of the important theme, that overarching theme comes through is, of course, changes to service delivery that may impact people's access and utilization of services. And so, for example, this harm reduction service provider explained, honestly, for us, the installation of the plexiglass and the space and telling people to stand 6 feet apart, it felt really bad because we're primarily dealing with people who are homeless, who have been incarcerated, kind of recreating the conditions of the trauma they have to live every single day. It has been really detrimental, honestly, to be unable to keep the kind of relationship that we want with our partners. Another quote is kind of gives you a perspective on from a person who is actively using drugs or was in treatment at that time. Let's see. So this is a 25-year-old woman. And when I talked to her, she was in treatment for opioid use disorder. And she explained her experiences. When I overdosed, I went to the emergency room, woke up there. I was supposed to get into a detox. They wouldn't let me in because I was exposed to an emergency room. So then they just denied me. And detox is the type of treatment for opioid that people with opioid use disorder attend. And this is the third quote is from a 47-year-old woman who was also in treatment at the time. And her complaints were related to telemedicine. I prefer to see somebody in person. I prefer to know that they are looking at me and I'm looking at them, especially a doctor. I think things get lost in translation easily that way. And so telemedicine became more commonly used. It's really expanded significantly. And it, of course, has an impact on people's experiences in relation to treatment utilization. Same. Another important thematic group that came through our interviews was, of course, COVID situation impacted personal and social lives in such profound ways. And these disruptions, of course, impacted people's drug use behaviors in very significant ways as well. So here is a quote from a harm reduction service provider. There's also been cases of people who relapsed and went back to the drug use because they lost their jobs because of COVID. A lot of people who get clean rely on their job. They rely on some kind of steady thing to do, steady work to keep them off of it. You know, and once that was taken away, a lot of them went right back to using. And there is another quote from a 25-year-old woman who was in treatment for opioid use disorder at the time when she was explaining her story. And so she says, it caused isolation and a lot of fear. And then, yeah, like all the positive supports in my life, I wasn't able to see. Everything went to Zoom in on the computer. So I no longer went to work. I didn't go to classes. I was just like home all the time. And my drug use got increased significantly. I was stuck in the same environment, same with my roommate. Everybody I knew who was in early recovery relapsed, and yeah, it just got scary. And the third aspect that was really came through very strongly in the interviews of both service providers and people who use drugs was this continually increasing proliferation of fentanyl type drugs. You know, as I was presenting to you in the previous slides, we have been seeing this trend in the past few years. It's been accelerating, but really people's perceptions are that during COVID situation, these increases became even more pronounced, more profound. So a substance use treatment provider explained, honestly, there has been a lot of patients who say that they struggle to find heroin. Like that's probably been one of the biggest changes, is that the heroin has become harder to find. And this is most specifically related to COVID for sure. And that fentanyl is still super easy to get. So I would say that has definitely changed during COVID. And a 42-year-old man who was currently still using illicit fentanyl explained in the following way. As I said, I didn't do blues before, and blues are the slang name for illicit fentanyl pills. And then he explains further, but it is so much easier to get. Like my roommate, he's got to drive like 8 miles to buy heroin, when I could literally walk out in the apartment courtyard and find 3 to 4 people selling blues. Because the only reason I started doing it, because it was cheaper and more accessible. So this slide, I believe, concludes my section of the presentation. I will be happy to answer any questions. I believe we will have that opportunity at the end of the session. Thank you.
Oh, Holly, I just wanted to say that it looks like you are on mute.
That is the entire theme of the COVID era, isn't it? Welcome back from mute. All right, well, let's try this again. Thank you, Raminta. That was great information and a very nice summary of more recent data concerning trends for sure. And as we've looked at these trends from a prescriber standpoint, there's certainly a lot of onus on us from a national guideline standpoint, from a state standpoint, from a federal standpoint, to get this right for our patients. And so many of the topics that I'm going to talk about here are more so about how we as prescribers can de-escalate the amount of opioids we're using for inappropriate circumstances, and then tailor opioids appropriately for those who need them. One of my favorite comments comes from Dr. Charles Mayo, the institution I'm with, and it's unfortunate that so few appreciate from what small causes disease come. We're talking about a pill, right? And sometimes just one pill.
Holly, I don't mean to interrupt you. It looks like your screen share is down at the moment.
Let's try this again. We're going to pull it back up. I apologize for the delay here. All right, screen share, and we'll go back to this.
Perfect.
Does it work?
It works.
All right, we're going to try it again. Is it up?
It is up.
Okay. So as we talk about deprescribing in the state of Arizona, state legislation in 2018 was released, and I'm sure many of us are familiar with this. SB 1001 had 4 major domains that required prescribers to greatly change their practices. These, for the most part, fell into the domains of prescribing limitations. As I'm sure many are familiar, we've got a 7-day maximum for opioid administration in individuals that are not surgical patients, and 14 days max for surgical patients. You'll actually find these a bit more liberal than a lot of those coming out for other states and even some of the CDC guidelines. We also have educational requirements. All of us should be completing 3 hours of CME on addiction or opioid related topics. The good news is that this lecture today will count for one of those hours. The state was not specific as to where you have to get this curriculum. As long as it covers these topics, you should be good. Just keep your CME credits and the topics at hand in case they're ever retrospectively requested by the state medical board. Medical students are required to have 3 hours of addiction education built into the curriculum. As many are familiar, Arizona Department of Health actually built a very robust curriculum plan for those individuals. They did a great job with it, and it's a good tool for even practicing physicians to utilize if needed. Electronic prescribing was put into requirements, and the initial bill required it in January 2019. That was extended an extra year, but I believe most of us are up to date and in compliance with that. And then, of course, there's the naloxone descriptions. So limiting all opioid prescriptions to 90 oral morphine equivalents a day unless pain management is consulted. And if you go over that, make sure that naloxone is given to individuals. What is lesser known in the medical community is the Arizona Department of Health rules. These came out, I believe, initially through emergency orders, and they have since been finalized, although they continue to be under discussion because some of the components necessary for integration can be a bit cumbersome for the practice. And so they're still in discussion on this. But the main elements include checking your PDMP or the prescription monitoring program. All of us as providers with DEA numbers should have access and be registered. Before prescribing an opioid, we should complete a physical exam on a patient or make sure that one was done recently. We should also have risk and benefit discussions with the patients on opioids. Many institutions have developed templates for this. There's discussions on whether a patient handout would be sufficient or whether this truly needs to be a verbal discussion. All of us should perform risk stratification of the individual. Many of us have turned to the opioid risk tool, or the ORT. That's an electronic calculator I will say that some of the drawbacks of the tool is that it's only been validated in individuals being placed on chronic opioid therapy. All of what I'm talking about now needs to be done in both an acute and a chronic prescribing setting. And so that's not the tool I would use. And we'll talk in a minute about different tools that are at your availability. Patients should be provided patient education. And so again, that comes down to a handout of some kind and feeds into the risk-benefit discussion. And then a unique component to all this is having patients signed informed consent. I think that's the part under greatest debate with the Department of Health, and they continue to reassess the value of this, but it is currently law, so please do keep that in mind. This is for opioid inpatient administration. So when your patients are admitted to your hospitals, these are requirements. This is for outpatient opioid prescribing as well. There are some nuances, how long a patient is expected to be inpatient for, whether or not all of these elements have been done within the last few months, whether or not you're doing it for the same indication. I would encourage you to actually read the law. It's on the Department of Health website under opioids, but some key and crucial components for us to consider. This includes emergency room visits, I will say. There are nuances that eliminate patients with active malignancy or those on hospice or palliative care settings. Clearly, facilitating all of what I've mentioned can be challenging. And so many programs have been initiated that oversee opioid stewardship. We have one at our institution that I oversee, and our opioid response working group construct includes all of the elements that you see below. As we reviewed which type of individuals to include in our program, we thought of each of the domains that opioid prescribing impacts, and this is what we came up with. So I would encourage you, your institution, to consider integrating the same types of components, because we really have found value in the opinions of each of these multidisciplinary areas. If you're looking for a good guide to initiate a program, I would recommend the September release of the American Hospital Association Stem the Tide Opioid Stewardship Measurement Implementation Guide. I had to practice that twice. There is also some additional supportive documents that come with that, but this is a great tool that really talks you through step by step how you engage these types of colleagues, how you would roll out a plan, how you would initiate metric monitoring, and then do reevaluation throughout the process. Internally, our enterprise at Mayo Clinic has reviewed state guidelines, CDC recommendations, and then best practice opinions by our own providers. For your information, we have a bit more restrictive prescribing guidelines internally. For most medical illnesses, some internal data has shown that we only need about 3 days for acute prescribing. Remember, the state gives you a 7-day limit. And then for severe medical illnesses, major surgery, trauma, and high pain expectations, we found that limiting the entire opioid prescription to 200 morphine mil equivalents and reassessing in under 7 days is actually leading to the same satisfaction rates that I believe we were receiving with longer prescriptions and much safer prescribing. When we do engage in chronic prescribing guidelines, it's important to understand definitions. In our situation, we've decided that anyone receiving morphine, oral morphine equivalents for greater than 45 days in continuity, and that includes a single prescription that's been refilled a couple of times, those individuals meet criteria for chronic prescribing guidelines. And so as you can see here, at the beginning of therapy and annually, all of the elements listed below are integrated. The exam, getting their history, searching the PDMP, using the opioid risk tool, having these risk-benefit discussions, getting a baseline urine drug screening, and then checking for depression, anxiety, their functional status, having them sign that opioid therapy agreement, and per DHS, the informed consent component. And then every 3 months, repeating the elements on the right-hand side here to make sure that they're in close contact. We do require our patients to be seen previously in person. And at this point, it includes telehealth visits. But as the pandemic drives down, I think that face-to-face encounter is key to make sure that you're looking all these elements over. As we're prescribing, opioid misuse can be a problem. And as Raminta has already pointed out, much of the pandemic appears to have stemmed with initial prescribing practices. There was a study done in JAMA a few years ago, and it showed that individuals that have a pattern of misuse or abuse when given opioids, in 27% of cases will use their own prescription. In a quarter of case, give it to friends or family for free. In another quarter of cases, sell them to friends and family. And in 15%, sell them as drug dealers. So identifying individuals that do have opioid misuse or abuse is absolutely key in your practice when doing prescribing. There was another study that showed, actually multiple studies, 4 in 5 new heroin users started out misusing prescription painkillers. And so we can oftentimes be the gatekeepers to what could be a very chronic problem. Identifying that chronic problem and dealing with it is absolutely key. The American Society of Addiction Medicine defines addiction as a primary chronic disease of the brain, and it's really built into 4 main areas: the reward center of the brain, our motivation, our memory, and then all of its related circuitry. Many of us who live in different areas outside of medicine see addiction as a problem, you know, very clear and cut to our own area of expertise. You know, in the judicial system, these people can be, quote, criminals. If you're a chaplain, these people have a spiritual problem, a problem of the heart. If you live strictly in the mental health world, they have strictly a mental health disorder. In the medical field, we see that all of these circuits really combine to create what we see as physiologic or phenotypic expression of the disorder. But the underlying problem from our perspective is really brain chemistry and underlying circuitry. According to the American Society of Addiction Medicine, dysfunction in all of the above circuits leads to the characteristic biological, psychological, social, and spiritual manifestations that we see. And then ultimately it's reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. So screening for misuse and abuse is key. The list below is not comprehensive, but some of the more common things that you want to keep an eye out for is the age group that you're initiating opioid therapy in. 18 to 45 age range is the highest risk for ultimately going towards abuse or misuse. Very high opioid daily requirements, underlying mental health disorders, big time, a big history of substance use disorder. As people have built these brain circuitry changes, highways, freeways that used to be dirt road pathways through the brain, they are easy to re-hijack when reinitiated on an opioid. So keep that in mind. Chronic pain disorder, bad personal living circumstances, even family history of substance use disorder. An unwillingness to participate in multimodal therapy. And then of course, if their baseline lifestyle functioning is not ideal, they could be at risk. Dose and length matter, and they matter to a great deal. There was a study done in 2017 that showed that even short-term prescriptions can come with significant risk of dependency. They looked at one-day opioid prescriptions, and there was a 6% risk at 1 year that individual would still be on an opioid. An 8-day prescription led to the risk that 13.5% of patients will still be using the drug at 1 year. And a 1-month long prescription, 1/3 of cases will still be using opioids at 1 year. If you authorize a second opioid prescription, it's just going to double the original risk for opioid at 1 year. So dose and length are key. What are the things that you're going to look for in an individual who may be misusing? None of these are true absolutes in most cases. And what's key to remember is that tolerance and withdrawal in the setting of opioid use equal dependence, not necessarily inappropriate misuse. These are natural side effects of the drugs, just like beta blockers or some of the other antihypertensives we use. If you put them on long enough, the body habituates. If you take it away, you get side effects. What could be misuse? If someone's changing the dose or the route or the treatment interval, red flags should go up, have that discussion. If they're using it for personal use indications other than prescribed, huge red flag. If they're doing it for entertainment, that's the time to sit down and talk about opioid use disorder. If they're giving that drug to other parties, this is one of the few indications to discontinue prescribing immediately. This is diversion, this is illegal, and we'll talk about that in a second. If they're accessing similar controlled substances from multiple sources, that's a no-no. Review the PDMP to pick that up. If there's a breach of the patient-provider contract, if they're overly hostile or aggressive during encounters, or if they're specifically requesting certain types of drugs, all of those can be red flags. If you encounter an individual and you are quite convinced that there is evidence for opioid use disorder, the true analysis is going to be performed via DSM-5. And I know many of us out there, including myself, are in the primary care field. We may not feel comfortable doing that. Please refer on oftentimes to social work within your own institution so that they can get these individuals into an addiction treatment program for full screening, or at least an addiction medicine, addiction psychiatrist to review. If you have someone with clear diversion, we recommend that you do not prescribe in these circumstances. That's a big no-no, and you could lead to a secondary overdose. There could be, honestly, criminal liability charges even on your own behalf as a provider. If someone is misusing and you have evidence of opioid use disorder, this is where it gets a bit challenging. The optimal treatment approach is to transition once they're diagnosed to buprenorphine, or treat them with a quick referral to a program that will prescribe it. If you can't get someone in early enough and you're unable to prescribe appropriately buprenorphine, which is less of a limitation since the 14th of this month, when now all primary care settings are able to prescribe buprenorphine, provided you treat less than 30 people a year. The alternative has been referring people with a short course of their current opioid regimen into a treatment program so that they don't automatically withdraw and turn to the state for illicits. As Raminta nicely pointed out, overdoses can happen very quickly with street drugs. There's been a study that 90% of patients that discontinue opioids without MAT will be on opioids again at 1 year. So it is absolutely key, once there is opioid use disorder, to send these people to appropriate treatment. Keep in mind, your therapeutic relationship might be their last line of defense to an illicit overdose. Patient counseling is key. And as we're making these transitions for treatment, keep the pain management mindset. Historically, we've approached all of pain management with this: we're going to get rid of your pain, that's our target. The reality is that chronic pain may lead to chronic dysfunction, and that target of elimination is not reasonable in most cases. We want to get people functional with their pain. And so this occurs through patient education, nursing assessment, provider responses, resetting institutional expectations, getting institutional support through an opioid stewardship program, and then relying on national requirements and guidelines to make those decisions. Keep in mind, there's some basic patient counseling things that should occur during every encounter. When you prescribe an opioid, make sure that they're not crushing, dissolving, or chewing any tablets or capsules. This can result in a fatal overdose. Tell patients how to handle a missed dose if not taking PRN. When their symptoms are controlled, tell them to stop taking the drug. They don't have to finish the bottle. Make sure they're clear that diverting medications to friends, to family is illegal. Get the drugs out of the house when done, and then give them clear instructions on disposal. They can mix them with unpalatable substances, scratch off all personal information off the empty pill bottle, or there's many drugstore receptacle disposal locations available. The big things to keep in mind, because that's a lot of information: tell them what's illegal, tell them what's going to kill them, tell them how to get rid of the leftovers, and tell them the side effects. So with this, I will turn this over to Adrienne, if I can figure out technology, and have her go over the basics of opioid use disorder.
Thanks, Dr. Guy.
Thank you. Stop share. There we go.
Great. So let me just pull up my slides here. One moment. Okay, can everyone see this okay? Maybe a couple head nods. Great. Okay, so Raminta walked us through kind of the trends in the opioid epidemic. And as we can see, we're still on this upward trajectory, unfortunately. And Dr. Geyer walked us through a lot of the prescribing changes that have been taking place. But as both of them discussed, not without some consequences, right? We do see some folks moving from prescription opioid misuse to illicit opioid misuse. We can't really talk about the future of opioid use disorder treatment without talking about medication-assisted treatment. So if you're not familiar with medication-assisted treatment, which I'll just refer to as MAT going forward, it's kind of a mouthful. we're talking about FDA-approved medications to treat opioid use disorder and alcohol use disorder in combination, hopefully, with behavioral therapies and psychosocial treatments. And it's a little bit ironic to talk about MAT as the future of opioid use disorder treatment because these medications have been around for many decades. So methadone, which probably has some name recognition for everyone, has been FDA approved for opioid use disorder treatment since the early 70s. Buprenorphine has been FDA approved since the early 2000s, but we still see pretty wide scale underutilization. I'll talk a bit more about that. So if you're not familiar with these medications, I'll just give the 30,000 foot level overview, but I'd encourage you to learn more if you're not familiar with them, because there is a lot of misinformation out there as well. So methadone, again, probably has some name recognition for folks. Methadone is what we call a full agonist, meaning it acts on and activates the opioid receptors. So we do see some opioid effect. We get very good control of cravings and withdrawal symptoms, which is important in terms of preventing relapse. It's very slow acting. It has a long half-life, which allows for daily dosing in a clinic. So that's occurring in an opioid treatment program, or OTP, what we've kind of historically referred to as methadone clinics, typically in a liquid dose to avoid diversion. Very affordable medication. It's on our access formulary, as are all of these medications. It's government subsidized for various patient populations. Then we have buprenorphine, or buprenorphine naloxone. Most of you probably recognize the brand name Suboxone. So Suboxone is a partial agonist, meaning it partially activates, partially blocks those opioid receptors. So there will be some opioid effect, but largely we're going to have a blocking of opioid effects, say if someone were to use illicit opioids. So like methadone, we're going to see some alleviation of those cravings, those withdrawal symptoms, little better safety profile than methadone, and also available in an extended release injectable formulation. And then lastly, naltrexone, which actually treats alcohol use disorder and opioid use disorder, the only medication that treats multiple substance use disorders. You may be familiar with Vivitrol. That's a once a month injectable medication. Naltrexone is a full agonist, meaning it blocks the opioid effects. So it's a non-narcotic. There are some concerns with this medication, or it may not be right for every patient, and that's largely because it can be difficult for some patients to start this medication because they need to abstain from opioids for a minimum of 7 to 10 days. And obviously when someone is actively withdrawing, that can be really challenging to abstain for that length of time. But we also have the risk of overdose if patients don't return for subsequent doses because their tolerance will be reduced. So the right medication for each patient really comes down to kind of that patient-provider decision. One isn't necessarily better than another. So who can prescribe? Dr. Geyer alluded to this. We've had some pretty major changes just in the last week. So previously, physicians needed a waiver from SAMHSA to prescribe buprenorphine, which required 8 hours of training. And obtaining that waiver through SAMHSA, a process that usually takes a couple months. But Health and Human Services announced last week that they are eradicating the waiver for physicians who are prescribing to 30 or fewer patients. So it will still be required for advanced practice providers, your nurse practitioners and PAs that might be on with us today. You would need 24 hours of training and still need that waiver. And then physicians looking to prescribe to more than 30 patients would still need the waiver. Methadone is going to be prescribed in opioid treatment programs, as I mentioned earlier, which are very highly regulated by the DEA. And then naltrexone can be prescribed by any prescriber in any outpatient setting. I should mention briefly, we provide free buprenorphine waiver instruction here at ASU. You can see the link there at the bottom of the screen, and I'm sure we can send it around with the slides and the resources. And you can also obtain free training through PCSS, the provider's clinical support system. So there's multiple means to get free training, get the waiver. So I just want to mention that substance use disorder treatment that combines medication with behavioral therapies has been shown to be more effective than behavioral therapies alone. So historically, we've often referred people just to behavioral therapies when we identify a substance use disorder, or perhaps just to, say, detox services. But really, we're going to see the best treatment outcomes when we add medications to the regimen. So the 3 medications that I just mentioned are very efficacious, particularly when we look at things like reducing mortality, reducing illicit opioid use, alleviating some of those cravings and those withdrawal symptoms. But unfortunately, even though these medications are very efficacious, we still see pretty wide scale underutilization. So we're seeing that both locally and nationally, which unfortunately deprives some patients of a medication that is likely to improve their treatment outcomes and very well may prevent their death. So it really becomes kind of an ethical issue, ensuring that patients get access to these medications, learn about the medications if they would like to start that form of treatment. And it seems, and much of the research would indicate, that this is largely because of misconceptions about the medications and how they work, as well as pretty tremendous stigma. So I'm going to speak briefly to some MAT policy changes that have come about due to COVID. So they're pretty tremendous changes, and they came about pretty rapidly, and really they were policy changes that patient advocates have been advocating for many years. So we kind of have this large scale natural experiment at this point in terms of what might happen with these large scale policy changes. And most were coming about really because of the need to continue MAT services during the pandemic, of course, especially because we know these medications have the capacity to save lives. And we want to continue to treat particularly those most at-risk populations, so homeless individuals, pregnant women, folks who use IV drugs, and so on. And of course, the treatment systems didn't want to contribute to the spread of disease. So I'll walk you through just a few of these policy changes. So one that was fairly significant, SAMHSA put out a memo in March of 2020, right when we were kind of stepping right into the midst of the pandemic. And this policy change allowed for patients to have 28 days of take-home doses for methadone or buprenorphine, which was a pretty significant change because most, say, methadone patients were coming in to the clinic for a daily dose, at least typically during a weekday. They might have been getting some weekend take-home doses. But many of these clinics they're dosing hundreds or even thousands of patients a day. So this really allowed for fewer people to be coming into the clinic, except for maybe those that were perhaps the highest need or greatest risk of having take-home doses. And this also allowed for even less stable patients to take home 2 weeks of their medication. So I know many of our local opioid treatment programs were doing pretty significant chart reviews to try to quickly determine who were the safest patients to take home their medications. Then we also saw a press release from the DEA also in March that allowed for telehealth inductions for buprenorphine patients. So historically, buprenorphine patients had to be seen in person to start their medication. This has been a major barrier in Arizona, particularly in rural Arizona, where patients might have to travel many, many miles, many hours to be inducted on buprenorphine and then continue to come back to that clinic for treatment for in-person visits. So this reduced a lot of barriers for patients, but this only applies to buprenorphine, not to methadone. And then that provider could continue that treatment via telemedicine. So the patient could initially be inducted rather on via telehealth and then continue to be seen via telehealth. And then I also want to mention CMS put out a memo in also March of 2020 that allowed for similar reimbursements rates for seeing patients either in their home or via telehealth. So what is this going to look like post COVID? We certainly don't have a crystal ball, but there's a lot of questions that folks are asking. One of which is, will the relaxing of these policies become permanent? And if they do, how might that increase in patient access affect our opioid overdose rates? And what might we see in terms of improvements in treatment outcomes or patient satisfaction? And or might we see some unintended consequences like we often do when we make policy changes? And then others have asked the really important question, which is, will these changes in policies or this relaxing of regulations play a role in the reduction of stigma towards patients who are engaging in MAT services? So we want to be part of the solution, right, at ASU, and we know all of you in the community do as well. And so we've thrown a lot at you, much of which probably seems like bad news, but we want to be a part of that solution. So we want to invite you to be a part of that as well. So I want to mention our medication-assisted treatment ECHO program here at ASU. If you're not familiar with the ECHO model, it's worth getting familiar with. It's out of the ECHO Institute from the University of New Mexico. So we meet bi-weekly on Fridays at noon via Zoom. We typically have a brief opioid-related treatment presentation followed by a case presentation from one of the providers in our group. Then they get recommendations and feedback from the larger group and recommendations from our hub of experts that runs the program. So it's a way to kind of continually be involved in these conversations. And for those of you that are in direct practice, to continue to enhance your own patient care. So in conclusion, as Dr. Goyer pointed out, we see that even short-term opioid prescriptions come with the risk of developing an opioid use disorder. So we've made some important changes there in terms of prescribing practices. But likewise, we need to create some strategies to ensure that folks don't just transition from misuse of prescription opioids to illicit opioids. And we really need some innovative strategies for overdose prevention. Certainly COVID-19 has impacted the treatment landscape in many, many ways, particularly these, like I said, this kind of natural experiment of some wide-scale policy changes. And we know that we really can't get a handle on the opioid epidemic unless we really broadly expand the utilization of medication-assisted treatment. We know that that's going to have to be part of the picture. So that concludes my portion of the presentation, and I believe we still have a few minutes for questions. I'll turn it back over to Kristen.
All right, thank you so much, panelists. I really appreciate your presentations and sharing your expertise today. We've had some activity in the Q&A, so I just wanted to kind of take a look at those. I don't see any new open questions, but please, we do have some time for questions, so please place your questions in the Q&A. But we did have a couple questions asked during the session, and Dr. Daniel Latite was able to answer some of those, and it might be kind of worth a little bit more discussion while we have a few minutes. So we had one question around, do you think that more availability around bupropion in the ED, the emergency department, would make a difference based upon the interviews that Dr. Daniel Latite has so far conducted? And so she was able to answer that. I don't know if you want to extrapolate a little bit on that.
Yeah, I want to add a few words to just this topic that I really explored in very deeply, because I still have a study that is running in Ohio on use of diverted buprenorphine. So how people are using buprenorphine that are getting on the street. And what we found is that even when people are using buprenorphine that are not under medical supervision, use of that drug helped reduce overdose risks for them. So we found a very strong association between use of diverted buprenorphine and reduced risk of overdose risk. So, but this is not related, I mean, the question is not related to diverted buprenorphine. It's related to expanded use of this medication, expanded availability. People who overdose, who come to emergency room, they're really in critical situations. You know, they have just died. That's how they say, I've just died. You know, they oftentimes they're in situations where they want to make a change. And if that moment could be captured and they could be linked to treatment in ways that are more profound and strong, you know, that might make a difference. So I believe that is very important to have those type of resources available for them. And if we're talking about fentanyl, just wanted to add one issue with fentanyl is that people who are exposed to fentanyl, we are finding that it's more difficult for some of them to start buprenorphine therapy. So there are some modifications in protocols, established protocols that are needed for these individuals, because fentanyl is a different type of opioid than heroin or other drugs that were, you know, initially were targeted with buprenorphine therapies when the clinical trials were conducted. So just my answer. Sorry for too long, too many minutes.
No, that's wonderful. Thank you. And we appreciate that additional information. So that's very helpful. So we had additional questions, 2 additional questions. I'll open these up to the panelists. Why do you think that the MAT, the medically assisted treatment as a term, is used primarily for opioids and doesn't include medications for smoking cessation, since the rationale is exactly the same? So great point, great question.
I don't know if you were going to say something, Dr. Geyer, so you unmute at the same time. I can say with medications for alcohol use disorder, we know that they're widely underutilized, just like medications for opioid use disorder. And I don't know that they, and this is strictly my opinion, I don't know that they carry quite the same stigma, both medications for alcohol use disorder and certainly nicotine replacement therapy. In terms of why we often don't lump nicotine replacement therapy in with MAT, I'm not sure. Certainly we sometimes do and talk about it that way. But I think especially with nicotine replacement and medications for alcohol use disorder, we just don't see the same stigma that we see hanging with, say, methadone.
Great. I don't know if Dr. Geyer, you wanted to add anything to that?
No, I think she summarized it nicely. They raise a very valid concept, and I don't know if it's just terminology and the rate that material comes out in industry and makes it to the general public. That's a great question.
Yeah.
And I think there are recommendations to kind of change the terminology, right? So medication for opioid use disorder, that's the term that is now kind of recommended for usage, right? But MAT is more recognized still, but it's changing.
Great, thank you. Another question, this is a great question. We have a couple minutes left. How do you think the legalization of recreational marijuana will impact the opioid, alcohol, substance use, abuse, and use within our, well, nationally, but obviously now within our state since the laws have just changed?
I'm happy to take that one. I think from the roads that I travel on with my colleagues, I've seen a variety of perspectives on this, and it's controversial. As I'm sure most people are familiar, when we talk about marijuana, it's often referred to as not being one of, quote, the gateway drugs. But the problem with that concept is that to be a gateway drug, you have to have the same mechanism of action as the likely drug you're about to abuse. Well, clearly binding to a cannabinoid receptor and an opioid receptor is a different mechanism. And so it's easy for, the communities that promote marijuana to dismiss this as a valid route to heavier drugs. I can tell you, I know a number of people in the field that are very concerned that individuals who develop cannabis use disorder or have frequency of use of cannabis for recreational activities will be more likely to go down the road of abusing other drugs. And there's multiple studies that corroborate that. I also have colleagues who sit on the other side of the fence and say, listen, if these are individuals prone to using something to palliate something in their life that they feel they need addressed, we would rather have them on cannabis. Is that pain management? Is that anxiety? We'd rather have them on cannabis as opposed to going to some of the heavier drugs like opioids. So I don't know. I think time will tell. I'd be interested in other panelists' perspectives.
And we're just about out of time. I don't know if anyone has a couple sentences to add.
Yeah, it's unknown.
Really fast, maybe under 30 seconds.
Yeah,
sorry.
under 30 seconds.
I would just say that our role as providers or educators is to educate the general public as well, because there's such a misconception about marijuana addiction and things like whether or not a patient might experience withdrawal symptoms when they try to cease their marijuana use, and all the cognitive impacts and all the long-term health impacts. So there's definitely kind of a lot of misconceptions in the general public about the actual health risks.
Mm-hmm.
Sorry, you were going to say.
No, it's great. Maybe this is a topic for another session. So with that, I'm going to stop our formal session. I just like to thank again our panelists all today for being with us and sharing their expertise. And I'd like to encourage everyone to check out the ASU Health Talks channel if you want to review this presentation again or share. We also have our social media channels as well. And I wanted to just give a little highlight to our next Health Talk session. It will be on February 18th. same time, noon to 1. And it'll be a very timely discussion around COVID-19 vaccinations, the benefits, the risks, and the hesitancies and next steps. So I know I won't be missing that. I'm very interested in that. Please again, remember to fill out the brief surveys that will be coming to you via email. And as Dr. Geyer mentioned, if you are a prescribing provider, this can count as one of your 3 hours towards those 3 hours that are needed for opioid and other substances prescription rights. So with that, I will leave us to the rest of our day. And again, thank you all, and have a very safe and good rest of your afternoon. Thank you.
Thank you.
Thanks, everyone.